Welcome back for our next panel discussion on diagnostics. The performance of A&Es across the country is hindered by the lack of patients being discharged for care off-site. As the need for care increases, resources for staff and beds dwindles, leading to the struggle of tackling the elective and diagnostic backlog. In 2021, it was proposed the NHS would receive £248 million to modernise diagnostics to help tackle patient waiting lists. This funding will enable hospital labs to share patient scans and test results more effectively between hospitals and GPs. In July 2021, the NHS set up community diagnostic centres across the country in shopping centres and football stadiums. Since then, they've carried out 2 million vital scans and tests as of October last year in order to help reduce the backlog made worse by the pandemic. The scheme is backed by £2.3 billion investment by the government to offer the public health services in the heart of communities. So with me to discuss the topic, we welcome Elaine Cloutman-Green, Consultant Clinical Scientist in Infection Prevention and Control at Great Ormond Street Hospital, Marissa Logan-Ward, NHS Non-Executive Director and Deputy Chair at the Stockport NHS Foundation Trust, Harry Jayaram, Consultant Ophthalmic Surgeon, Glaucoma and Cataract at Moorfields Eye Hospital, and Matt Inada-Kim, Consultant Acute Physician at Hampshire Hospitals NHS Foundations Trust. Don't forget to join in with the conversation by using our Q&A function, which I must remember to turn on, which is at the bottom of my screen, but on the right-hand side of your screen. So how nice to put my glasses on and see that we've got so many familiar faces for this panel. Lovely to have you all back. Marissa, how will this £248 million investment that was announced in 2021 in digitisation of tests and checks and scans help faster diagnosis, do you think, and of course reduce those ever-growing waiting lists?
Good morning, everyone, and thanks for the question, Helen. I mean, nobody's going to turn away that sort of investment in diagnostics. I think from somebody that's worked in laboratory medicine for over 20 years, we've always been seeking additional diagnostics to modernize, to transform. But now there's such an emphasis on tackling those backlogs. What we've found, certainly in the Northwest, there was always a lack of investment, particularly in laboratory information systems. Some of that, what I would consider the absolute baseline of what we're trying to do. So I think it's welcome. And I think there are ways in which we are using it really disruptively. So, for example, in digital pathology, digital histopathology, it's been used to procure scanners and to try and facilitate we're on a precipice really of a disruptive technology in diagnostics. So there's a real push to drive histopathology, which is traditionally on glass slides, a very manual process, open to slides getting lost, quality issues. And the investment has been used quite a lot to invest in that. My caveat to that is that we are investing in hardware and technology, and sometimes we're doing it without doing some of the groundwork first. And I think there's something about looking at our workflows and how we deliver services before we impose the digital solution on top. So there's an opportunity there to address some of the backlog for histopathology reporting, which of course is so key in the definitive diagnosis for cancers. But there are other areas as well, particularly in scan technology, for remote consultations, for point of care, which is traditionally, or it's not traditionally, but quite often isn't integrated into our central system. So we are using it, but I sort of have a bit of caution that whether we're using it appropriately and sensibly, and will it have an impact on the actual backlog, diagnostic backlog themselves.
Elaine, I'm curious to know whether you're feeling the difference from it at Great Ormond Street, and if you are you using it disruptively as well in similar fashion to Marissa?
It's a really fascinating area. So I've often felt that healthcare scientists particularly are kind of like the Cinderella workforce, right? We live in basements, no one ever sees us, but we kind of produce things that sort stuff out, but nobody ever comes and actually works out where we are or what we need. I think anything that raises awareness of diagnostics is amazing. I have some real concerns about the fact that my workforce are often not invited into the rooms where the discussions get made about what to buy and how to do it and how to look at that pathway flow. And so sometimes the focus isn't actually on the things that make things quicker, that really make things change. They're on the shiny things that people think are exciting in terms of moving advancements forwards and new tech. Whereas actually sometimes what we need is the really simple stuff that will enable us to do things faster and better, and have of what we're doing and really embed it in order to change patient outcomes. I also think that Great Ormond Street we're incredibly fortunate because we have a lab on site. A lot of hospitals don't have their own labs anymore. They've been put into cores and hubs, and that means that the specific patient need is not necessarily the same across all of those hubs, and it's quite hard therefore for the diagnostic process to really support the individual patient need that each of those hospitals have, because they're all centralized. Obviously there are benefits to centralization, no one's challenging that, but it's always going back to putting the patient need at the center of everything we do in order to make these changes in a way that really make that difference for waiting times and also quality of care.
Absolutely. And Harry, I'm just wondering, what it's like at Moorfields. Where do you fit into this jigsaw in terms of that money, the investment, digitalization of tests? Oh, we just need your sound, Harry. Oh, there we go. There we go. Start again if you don't mind. Oh, I don't think I've still got you. Harry, just try one more time.
Can you hear me now?
Now I can, yeah.
You can, fantastic. Yeah, so we're an eye-only hospital, so the sort of slightly different issues we're dealing with, but our workload is hugely diagnostic based, and we were one of the first places to sort of set up a massive eye clinic in Brent Cross Shopping Centre in North London, and we set that up about 18 months ago. I think we sort of actually got this going just before the government released their plans to do this, and it's revolutionised things as to how we've dealt with our backlog. So we've pretty much cleared our backlog and been able to help with neighbouring hospitals, where they would accept help as well. There are several things that we've done. We sort of ran our implementation as a research project. So we had some funding from the NIHR. So the project was called Project Hercules, and we were essentially trying to work out what's the most efficient way to see patients and manage them in this sort of diagnostics-based pathway. And one of the things that we learned was the IT infrastructure in the NHS, I think nationally this is the problem, is not the best. So there were simple things like we had huge amounts of imaging performed outside of a hospital setting that we needed to sort of transfer back into the central site and across to whoever was reviewing them, and the bandwidth of the data and the broadband connections wasn't ideal. And I learned that if you want to get a new BT line, it can take 3 months for them to plug it in, and there's no prioritization. So there are these really sort of tough practical issues that, despite fantastic investments, the obstacles will come around. The other thing that we learned was workforce. So we took on people that had lost their jobs during the pandemic, and we decided that we wanted to prioritize recruitment into people that were in, let's say, customer service facing specialties, because if they could make patients feel safe whilst having their diagnostics, that was all we wanted them to do. So as long as you were feeling safe in what you were doing, and I've experienced that as a patient as well, so it was quite interesting. So we heavily involved our patients and our new sort of diagnostic technicians in getting feedback about the projects, and that has sort of informed how what we've done. And we've had to take on technology as well. So things like remote consulting platforms like the Attend Anywhere platform has really revolutionized things across the NHS. I think first of all it was during COVID, but I think it has made things much more accessible. And I'm all for technology, but the big caveat that I'm very wary of is this concept of digital discrimination. If you've got someone that's for cultural reasons or age reasons just can't engage with this sort of technology, like for example, my mum, there's no way you'd get her on I struggle to get her to use FaceTime and WhatsApp. I think it's very difficult to have that as the only means of communication, but there has to be some sort of compromise.
Oh, it's such an important topic that my mum's just delighted that at 80 she's discovered espresso martinis and the Wordle.
Wow.
Amazing.
Yeah, she's doing very well. Matt, sorry, you're kind of at the end of my panel there. Do feel free to add to anything our other guests have said, but I was going to ask you about diagnostics in acute community care or virtual wards even. She says, putting her teeth back in.
Yeah, so hi everyone. So I was one of the national leads for COVID virtual wards and assessments, and then virtual wards themselves. And now I'm leading on acute respiratory infection assessment hubs. So very much in the acute sector rather than the chronic per se, but I don't really see the distinction between the two. I think these CDC concepts and increasing diagnostics within community settings is a godsend for both. I fully agree with Marissa's point about involving clinical scientists and Elaine's point about involving clinical scientists right from the start in these processes. And that's something we've tried to inject into our national programs going forward, so that we have a multidisciplinary workforce that decides and determines policy, practice, guidance, and funding for these hubs that involves the people doing the tests. Because without that knowledge, you're not going to get anywhere. I think the distinction between acute and chronic can sometimes be harmful, because patients lie on a continuum between them. They have chronic conditions that episodically become worse. We have expertise potentially in community hubs, which needs to be activated for both acute and chronic conditions, not just for chronic care, and certainly not just for acute care. So for me, there is a pulling together piece where we agree that blurred lines are acceptable within what we are trying to provide in terms of tests in community settings, particularly for general holistic care. So I'm not talking about specialist, individualized, minor or small areas. We're talking about general, conditions of extremely large volume and of large complexity and multimorbidity. And I think by accepting that, we can then start on a proper footing that actually meets the need of the population. Because the population are not really fussed about any particular silo care. But what they want is the ability to access tests. And what the pandemic has really taught us is that it's no longer enough to just have someone's word that a patient is going to be okay. Patients want tests, and they want them soon, and they want them within an acceptable quality standard and reporting mechanism that enables them to feel reassured. And if we don't provide that, they're just going to go to the hospital.
Yeah, which is why, of course, the personal contact, that Harry was mentioning is also so important, because when people have got something wrong, they need reassurance, and digitalization is brilliant, in many, many ways, but it still needs to be mixed with people feeling safe and feeling like people, that it's not all a digital solution. Just while you're still there, Matt, Carol just says, what about the use of artificial intelligence in diagnostics? Is there a lot of AI in diagnostics?
It's coming. So certainly, I did a talk recently at RSM on this, but essentially from a radiological perspective, absolutely. And there's quite good evidence now demonstrating for instance, reporting of radiology scans and X-rays. Yes, there is growing evidence base. We need to be careful of walking before we run in terms of the replacement of staff, which I don't think you can really ever do. I think there is something about the high volume, low risk reporting that might be a good first step in terms of how we prove the model and how we assist clinical care and obviously patient access, because that reporting backlog is massive. In terms of a more general artificial intelligence usage to actually determine where best value is within diagnostics, which we're talking about from a population and epi scale. I think there's huge potential for actually determine what society needs in terms of diagnostics at different points of their lives and also different geographies. Is the same requirement present, for instance, in an area of deprivation and high ethnicity compared to one of affluence and non-spread of ethnicity? I would argue they may have very different requirements. And
Absolutely.
my last point would be not to separate the digital from the clinical.
Yeah.
So one of the key elements of all tests is that you have to have assessment within it. And my worry about separation of diagnostics and diagnostic centres into pure diagnostic spaces is that we lose that. And we just need to be really careful about offering a test for everything without actually any clinical input. Because I think the two in separation could lead to a lot of inefficiencies and a lot of ineffectiveness.
Absolutely. Elaine, do you want to add to that?
Yeah, I just want to also follow up with the caveat that actually sometimes over-testing is harmful. And so what we also don't want to do is put ourselves in a scenario where people test for everything at every point, because that can also lead to over-management and other things that can be quite detrimental. You know, in my world of pediatrics, if you start taking lots and lots of blood from a child that doesn't need to be taken, that actually has a negative impact on their health and well-being for that day when they're having it done. And so it also needs to be targeted, well thought out, and part of a pathway. If you're testing for something, there has to be an action that you can do as a result of that test. We shouldn't test for test's sake. And sometimes I think if people aren't putting it into that pathway perspective, we end up just taking tests because we can, not because they're actually guiding the next step for that individual patient.
Marissa, I mean, there are clearly inroads that are being made with respect to the National Elective Recovery Programme, but patients are still waiting longer for treatment. How does this impact outcomes, and what can we do to mitigate it?
Yeah, it's I think the first thing I'd like to say is, you know, just to acknowledge the incredible inroads that have been made over the last few months. I mean, the numbers of patients that have been operated on since that backlog was really seen in its full technicolor is incredible, and we've made as a NHS such an impact on the 104-week waits, the 78-week waits, those really long waiters. But there's still a lot of patients waiting, you know, a year plus. And even those that are waiting less than a year, if they've been referred for surgery, they need their surgery. So I think in terms of outcomes, anybody that's waiting longer than they should be for a procedure is not going to have the best outcome for them. And I think from a board perspective, so I was chairing our quality committee throughout the pandemic and have recently moved to a different committee. But what we wanted to do was at the beginning, when the backlog was at its worst, is we needed as a board to get assurance that whilst we understood that many patients were waiting a long time, what assurance could we get that actually, you know, we were minimizing or eradicating the potential harm that could come to those patients while they're on the waiting list. And at that time, there wasn't really a sort of regional or central approach to how we got that assurance. So we kind of did it in incremental steps. First committee was, you know, quite a sort of basic, you know, where are we up to? What's the process? And we got assurance on the clinical prioritization process for patients. You know, how do we look at that list and determine who should go where in sequence? So we got assurance on that. And then we built that up around looking at how do harms reviews take place? How are we clinically looking at these patient lists and ensuring that, you know, we've got a really good eye on the patients that are waiting and reducing the potential for harm? And that's just grown over the last year, looking at how we liaise with GPs, because that's a really important relationship that we need to have as acute trusts. And now sort of towards, you know, sort of 18 months on, we have embedded in our assurance frameworks good mechanisms for just keeping an eye on those waiting patients. So it's not great, it's not ideal. We've got lots of patients waiting, but we have more assurance on minimizing harms to patients. Not saying that they don't exist, they do, and we're aware of them and we're addressing them. But also, I can't remember who brought up the equality point, but we're actually able to look at these waiting lists and just give ourselves assurance that we haven't got certain demographics that are disproportionately waiting for certain elective procedures. So, I mean, we're in this position. I think there's been great inroads that have been made, and we're looking at how we minimize the harm to waiting patients. But I can't say that we're anywhere near actually maximizing outcomes for patients in this current climate.
Yeah, but you're so right to say that we should still reflect on the inroads, because, you know, there have been many positive inroads. Harry, a question perhaps for you from Inayat Khan. Good points by Marissa and Harry. Different specialties have different diagnostics, diagnostics/imaging. The focus has been mostly on CT scans, MRIs, etc. It is more than that in ophthalmology. I'm so struggling with my words today. We need to look at retinal disc images, OCT scans, field tests, etc. We embraced the change in Hillingdon and tried to clear the backlog in a more efficient way, but we find that there's a shortage of IT staff at hospitals for networking equipment and for ongoing troubleshooting. We need to increase our IT support workforce to ensure we do our work without interruption. Additional IT funding is urgently required to make these services a success in the long term, and that fits in nicely with what I was going to talk to you about IT infrastructures in hospitals. Harry, do you agree there with Inayat?
Yeah, no, I can completely agree, and I think it's a problem that not just ophthalmology has. I think all hospitals that are very data driven have. The classic example was this summer when we had the super hot weather. A small computer part in the St Thomas's servers burnt in the heat, and Guy's and St Thomas's were without any patient records for about 4 or 5 days. And everyone in London was affected by it, I think, because of they couldn't do anything. They couldn't even phone the patients to cancel them because it was all on their EMRs. So I think this highlights, there's so many facets to this. I mean, if we just talk about the diagnostics to start with, so ophthalmology is very sort of technology and kit driven. For all of our patients that we used to traditionally bring into a face-to-face clinic for laying of hands by the doctor, everything can be done in a diagnostic pathway in terms of, you can pretty much image everything for most of the big sight-threatening specialties like retina and glaucoma. So that's why we've managed to push ahead with high-volume diagnostic hubs. But then, the issue is with the data you capture, is that going to be reliably stored and saved? We've had issues where the servers are down and then you can't do anything. We had 1 or 2 days in the last year when patients came in and all of our systems were down, so we had to send them all home. So you are at the mercy of your IT, and there's I know at Moorfields there's significant investment into improving IT. One of the things the NHS hasn't really done, but I think is moving towards, is using cloud technology. So traditionally, NHS hospitals have big servers in rooms, scattered around, and that's where the data is stored. So you are putting yourself at risk because if something happens to that server, as happened at Guy's and St Thomas's, literally the whole system fails. So I think we are all, and certainly NHS Digital as well, are working towards embracing cloud technology. I think it's really just having reassurances on the security and the safety of the data in that sort of setting, and that will make things safer. I remember 20 years ago as a junior doctor having some management consultants were coming around asking about how can we improve IT, and I think we can all confidently say it's still a major challenge for all of our trusts. The other important thing to talk about is electronic medical records, and these are really sort of intrinsic to being able to sort of manage patients with diagnostics. And I just want to echo Matthew's point about tests shouldn't be done just for the sake of it. Ophthalmology, you mentioned some of the tests that we do, all sorts of imaging devices, and it's not a binary finding from one test or the other. That's where the clinical decisions have to come in. You've got 4 or 5 pieces of information that need experience and decision making. And the danger about too much imaging without an electronic medical record is that you get a lot of false positives, which then come into the hospital and get overloaded. So for ophthalmology, if you go to have your eyes tested on the high street, Specsavers have all the kits, they will do all the tests. They don't necessarily have the expertise to interpret them. So you'll get the Rolls Royce of testing, but you may end up with more worry and concern than had you not had the tests. So that's where the EMR comes into it. And electronic medical records, there's so many around, and certain ones are very, very expensive. Great Ormond Street will know that they have a relatively new EMR that's come over from the US, And it's very, very expensive, but it's pretty efficient once it works and once the culture has changed to use it. For ophthalmology, we have some sort of custom EMRs. There's 1 or 2 in the country that are used. At Moorfields, we use one called OpenEyes, which is sort of open source, and we have input into its development. But there are factors with that as well. So if those servers are down, the whole system falls apart. So we are at the mercy of IT.
Wow.
And I think that goes for all specialties, really.
Elaine, I'm wondering, I know you're passionate about IT as well at Great Ormond Street, and whether there needs to be more of a process approach to dealing with the sorts of issues that Harry was talking about. Diagnostics do frequently require, don't they, more infrastructure investments, things like ventilation, perfect example that Harry just shared with us, and server and cloud availability. Give us a sense of what you're doing at Great Ormond Street to overcome.
So we have an entire kind of section of GOSH called Drive, which is looking at how we deal with IT and new advancement to actually really impact on patient care. I would say that we have a lot of cloud server stuff at GOSH, but then when Amazon get a denial of service attack and everything goes down, even cloud is not perfect, because then you can't necessarily be able to access yourself. And so it's really starting to think about how we see this as a jigsaw puzzle with how we put those pieces together so that we have that resilience for individual clinics, but also in the wider data set. Because how long do you have to keep this data for, right? It's not like we're just keeping it for a few months. We're keeping it for at least a decade in most of the cases. And so that builds up quickly, and suddenly you have to be looking at huge amounts of data storage that needs to be massively secure but also accessible. And so there's some really exciting stuff going on in terms of how we move that forward. There's some really exciting trials going on, and I think that one of the great things about the current diagnostic landscape and this introduction of this as policy, it means there's now going to be a direct route for how we get that into practice, rather than just something that sits very nicely and goes, oh, we have this amazing thing, if only anybody was interested. We now have a direct route to translate into service. And I think that gives us huge potential and huge optimism for what can come over the next 2 to 3 years.
Matt, I'd like to bring you in on Centres for Disease Control. I mean, the NHS carried out 2 million scans and tests through CDCs. I'm just wondering how you think they've done, and whether they could cater more for diagnostic needs of both community urgent and non-urgent care.
I'm not sure about the quality elements of it or safety elements. I haven't done enough research personally to ascertain the differences between the community delivered versus the hospital delivered points, but I presume they'll be pretty similar. There's a lot of hospital systems have been involved in the governance perspectives, and obviously the staff and processes. So I think it is a work in progress in that regard. I would like to better understand, I guess, the overall demand in terms of tests, and whether CDCs could be a more fluid space so that we do that bridge of acute and chronic well together, or chronic and preventative, I should say. And thinking about, I guess, elective and non-elective activity and what we are trying to impact on, which is not only access for patients, but also flow and to be quite honest, the survival of the NHS. We have different time periods when people become acutely unwell. We have potentially a different time period where we can do acute, more chronic and more subacute investigations. And I just wonder whether within the same space we can do both. And then we can also add in clinical assessment rooms so that we have clinicians on site to actually interpret and act on the results from your diagnostics at exactly the point where it's needed, i.e. the point of testing. I think the more steps we put in and the more places we ask people to go, the more subject this is going to be to a failure model. And for me, we need one-stop shops for that reason. I'm mindful of the fact that we don't have this system up and running adequately yet, but I'm also mindful of the fact this is an opportunity. This is an opportunity for ICBs and local organizations to actually innovate, push the envelope, and actually be quite brave in what needs to be done. And the national team are looking for answers. They're looking for exemplars. So go out there and create what works best for your population, and then come back and share what you've done, would be my my parting words.
Marissa, will you give us your thoughts on CDCs and the positives and negatives that you can see?
Absolutely. Well, it was really interesting to hear Matthew's take on how